Well, welcome everyone to the next iteration of SPRY webinar. And today we're lucky to have Dr. Rebecca Griffin with us for this particular episode. And first, I would like to introduce Dr. Griffin to our audience. So Dr. Griffin is a specialist in emergency department care. She is a physical therapist by training. Dr. Riffer believes that physical therapy practice in the emergency department is a critical way to move upstream in healthcare that supports patients during their most critical moment. Dr. Griffith has been a invited lecturer, regular presenter, podcast guest, article contributor on this topic. She is the author of Top of Scope, the Emergency Department Physical Therapist Handbook, which we will provide a link to at the end of this webinar. Additionally, she has been instrumental in passing 2 motions within APTA House of Delegates in support of emergency physical therapy practice, and is founding member of Emergency PT Steering Committee and the Academy of Acute Care. The EDPT will prepare you for successful practice in the emergency department, and Dr. Griffin has been, once again, a pioneer and a leader in this field. Her mission is we make emergency department physical therapy well-known and well-practiced, and her value is physical therapy should not be a luxury. Physical therapists are integral members of the multidisciplinary healthcare team and add tremendous value to patients, hospital success, and emergency department in increasing outcomes and access. So without further ado, thank you for being here and welcome.
Thank you. I'm really excited to be here, and thank you everybody who's spending their time with us today. I really appreciate it. I'm a little sick, so I might sound a little bit funny, but appreciate your grace with that, and I'm really excited to be here.
Thank you. And it is absolutely a privilege. So just to give it a little insight, I have known you for just a little bit of time, and I have heard you speak on a national forum. And I think I have yet to see someone who is more knowledgeable and more articulate in both your domain of expertise, but also globally on the field of allied health and physical therapy care provision. So I think you have done so much already to our profession. So it really is a unique privilege to have you as a part of this webinar. So thank you for being here. You are awesome. So the first question for you is, you have made it your mission to make emergency department physical therapy a well-known, well-practiced act. At what point did you realize that there's both an opportunity and a missed access to allied health services in an emergency medicine department?
Well, I think that if I just tell this story now, like it'll kind of set the tone for the entire conversation. Have you heard this story about upstream and being upstream in healthcare? So basically the best story that I like to share about that is like you're out by the river, you're enjoying your day. It's Colorado, obviously where I live. And there's a kid drowning in the river. So you jump in and you pull the kid out of the water and you're like, oh, wow, hero of the day. I just saved somebody's life. I'm amazing. But then you turn around and there's another kid in the water. So you jump back in the water and you start pulling that kid out. And then there's so many kids. And so I say, Alex, I need you to get in the water with me. We got to get these kids out of the water. And so we're pulling kids out of the water like crazy. And we can't even like look up because we're so busy. But then you get out of the water and you leave me behind. And I'm like, where are you going? And you turn and look at me and you say, I'm going upstream to figure out who's throwing the kids in the water, right? And so I think in healthcare, we forget often that we need to get upstream. And the emergency department truly is one of the most downstream, bottom of the waterfall places in healthcare. And unfortunately, for a lot of folks, it's their only access point. And when we talk about physical therapy as a luxury, so many patients that access the emergency department have never heard of a physical therapist, certainly wouldn't know how to find a physical therapist, don't know what to see a physical therapist for. So all of those things sort of contribute to why we need therapists, whether they're physical therapists, occupational therapists, speech therapists, behavioral health therapists in the emergency department. It's also where like the folks who society has forgotten, that's where they go to get their health care. So I like to think of the emergency department as being upstream at the bottom of the waterfall.
I think it's right on. And I think it's like you're providing access at the point, at the threshold where most people consume who don't have access through other medium. So that's so important. And then like that is terrific. So just as a housekeeping note, anyone who is looking at these slides, there's a QR code attached to the slide. The QR code will take you to a PDF article that supports a lot of what Dr. Griffin is saying. And these are the articles that are either published by APTA or support the journals that can help you organize your chain of thought around some of these concepts and these issues. So with this, I would like to ask you then the second question, which is more on a domain of physical therapy in general. That I think that the physical therapy market and physical therapy access point is a lot of times seen as more of a luxury than a necessity. How does having a physical therapist within a emergency department democratize that process? How does it improve access, but also how does it improve utilization of this vital service in the community?
So I think there's a few pieces of that, right? Like physical therapy is a luxury from many standpoints. One of those standpoints is cost. So like I have a $6,000 deductible and I have a great health insurance plan. So if I want to see a physical therapist, there's a significant cost associated with that. There's also significant value, but sometimes when people are making the decision between are they going to get their prescriptions filled, are they going to eat, or are they going to go to physical therapy is often going to be lower on people's lists, right? It's also very time costly. And when we talk about access, it's not just money. We tell people choose PT first, but how? If you wanted to see a physical therapist today in your community, could you do that? I know in mine, probably not. Like if I had an acute low back pain problem right now and I was like, oh my gosh, I should see a physical therapist, I probably wouldn't be able to find one that I could see today. So where am I going to go? I could go to urgent care. I could go to the emergency department. I could probably find 4 different chiropractors to see. There's a lot more accessibility there and availability. So I think the other part of access is if you don't know who to access or how to access, you're also not going to do that. So in the emergency department, we also have folks who can't access healthcare because they don't have the money. They may be unhoused. They might not have the health literacy. They might have other safety concerns. They might be working while all clinics are open. There are so many reasons why somebody might not see a physical therapist. Additionally, they may be taken by ambulance directly to the emergency department without really having much of a choice or not knowing any better. So by having a physical therapist immediately in that setting, you can sort of address those concerns no matter who the patient is, right? No matter why they came to see you, and you can get them physical therapy right away. The other thing we've noticed is that when we see physical therapy or when we see patients for physical therapy in the emergency department, they're much more likely to access downstream physical therapy. And when we think about that, I call it like the Costco effect. You go into Costco thinking you're going to get just the bag of Dino Nuggies, and you're pretty excited about that, but you're not going to get anything else. And then you meet the sample lady, and the sample lady's like, you should try these sweet potato French fries. They'll go great with your Dino Nuggies. And then you try them and you're like, wow, those are great. And the next thing you know, you have a 50-pound bag of sweet potato fries in your cart. It's the same thing with physical therapy. If physicians just refer you to PT, you're unlikely to go. But if you get to see a physical therapist and you get for you the value that we can offer, the self-efficacy that comes with that, then you're way more likely to access that downstream appointment.
Yeah, right on. So there's actually an interesting statistic that when a primary care professional, primary care physician refers for physical therapy, the actual access, only 24% of those patients referred wind up consuming any form of physical therapy. So the point of engagement is pretty low. And the path dependence is probably cultural, right? The way we consume healthcare is path dependent, that you go through the typical steps. And before you know it, it's been 3 months, you've seen 6 different professionals, and you racked up $6,000 worth of cost without any improvement in outcomes. So have you found that having this early access through emergency department has any impact on global cost as well as satisfaction with care from consumers of allied health services?
Definitely. So what we found directly in the emergency department is there's a much larger decrease in unnecessary care. So I don't want to say like there's a decrease in care, because sometimes we're actually recommending an MRI. Sometimes we are recommending admission. But I would like to say that we provide more appropriate care. So there's a decrease in cost of unnecessary imaging because we're not doing that. There's decrease avoidable hospital admissions. We're not admitting folks to the hospital that don't need to be there. We're also not sending patients out with as many opioid prescriptions, which also we know has better outcomes. We're making recommendations for patients to return to activity and work immediately. So if you come in, say, like with a work-related injury, I can tell you right now, I want you to go back to work. Here's how I want you to modify it until you follow up with your workers' comp physician, for example. So there's a lot of like maybe not cost generation or income generation, but there's a lot of cost savings by having a physical therapist in the emergency department. The other thing that I think of is like the cost to the patient, right? I may be the most expensive physical therapist in the state, like the cover charge is huge. But if that patient gets their function back immediately, as opposed to 6 weeks down the line, then I've saved them 6 weeks of their life where they could be out functioning. So I think those things have been shown to be really cost effective. We don't have a tremendous amount of data showing that patients that are seen in the emergency department and that downstream follow up, because it's really hard for us to follow up with those patients. But we are seeing that there is an immediate cost savings. And my favorite part is patients love us. When you think about people going into the emergency department, how many people do you know that have gone to the emergency department and then they say, I went to the ED and they did nothing for me? They did, right? Like they made sure you weren't going to die, or like your arm wasn't going to fall off. But the satisfaction level there is low. But if we can bring time, touch, empathy, and humanity into one of the most vulnerable moments of somebody's life, then patient satisfaction is through the roof. They feel heard, they feel examined, they feel taken care of, and they feel prepared for what's next. And like, no shade to our other healthcare provider colleagues, they don't have the time for that. The infrastructure is not set up for that. So we're uniquely positioned to help with that. And because we're providing that service, that cost-effective throughput, that patient satisfaction, guess who else is really satisfied? The physicians that we're working with, because they can be the right provider at the right time for their patients, and we can be the right provider at the right time for our patients.
Yeah, you become a vital part of the entire healthcare ecosystem. So you're an integral part of the ecosystem. And based on that default point of entry, have you found that there is some pushback from someone who doesn't expect to see a physical therapist and has a more of an ingrained model that, let me just see, you need to see an MD before you get to any physical therapy? And what are some of the steps that you use to educate these patients about your fit for this specific access point?
So do you mean like a barrier for a patient feeling like they shouldn't see a physical therapist, or do you feel like a MD feeling like their patients shouldn't see a physical therapist without seeing the MD first? Because I think those are two sides of the same coin, right? How do we fit in the healthcare continuum?
I think that's perfect. So why don't we tackle both? So why don't we tackle first when the patient gives you some pushback that I want to see an MD, and then we can talk about the MD saying that I don't know what physical therapists are doing in the ER.
Well, I'll have to give our physician partners credit, right? Because a lot of my physicians will say, this is Dr. Griffith. She's going to evaluate, treat you, set your plan of care. If I'm needed for anything else, I'll be happy to assist. So that setup really helps foster like public trust. But the other thing is, I just really find that as soon as you come in that room and you develop that therapeutic alliance, you listen to the patient and you tell them why they're there. First of all, seeing a physical therapist, I tell patients, is really reassuring. It means there's nothing dangerous happening. It means that you're safe, and I'm here to help make sure you get what you need out of this visit. So the number one thing I'll ask patients is, what were your expectations when you came into the emergency department today? What did you feel like was going to happen? And what does success look like for you in the emergency department? And if success does not really align with what I can provide, then I won't see the patient. I can educate them on the value I could provide and how I could help them be successful. But if it's really not within their goals of care, it's not within their goals of care. But I find that patients really, once they talk to you, you receive their history. You don't take their history. You can understand what's important to them and how you can really facilitate them getting out of the ED quickly and in a like very holistic manner. So I find that once you start talking to patients and you demonstrate who you are as a professional, I mean, I've almost never been sent away. I've had a couple of times where people might be really aggressive and angry. You know, it's all about like helping people regulate. So I usually tell people, don't ask for anything from your patient or do anything to your patient until they're well regulated and their basic needs are met. And then it's super easy.
Yeah, it's right on. And I think that what you were saying before, when a physician or any member of the care team frames your presence as being something that is of competence and value, that you no longer have to assert your own value in the patient's eyes, right? It's just a matter
And
of
standard of care
yeah, exactly. And you become again the
is
default
the
up.
standard.
Have
Exactly.
you
So sometimes too, they'll say, Dr. Griffiths is going to give you a second opinion.
Mhm. Yeah, and you
I love
become
that.
connect, and you have you're a stakeholder in the individual's well-being. So you no longer have to prove, you are creating a more of a framework of competence and autonomy, right? Agency. You're the agent and the care delivery. So
Exactly.
let's talk then a little bit about recovery trajectories. And I think this is always an interesting part of we see, I think, especially in allied health, each encounter as an episodic encounter. So we fail to see the entire longitudinal trajectory of most of these musculoskeletal problems. So have you found that this early access to competent and evidence-based clinical triage in emergency department influencing downstream trajectories, both clinical outcome based as well as financial expenditure based?
I think so, right? And it all goes back to that point of right provider at the right time so the right decisions can be made. So if you have a patient coming in, often with musculoskeletal triage, those patients will be like low priority triaged. So they're not like emergent. And a physician might put in an order automatically, like this patient obviously is going to get an x-ray because they have ankle pain. Like a lot of those things just happen by default. They're in the algorithm of care. So now that patient is waiting for an image they don't need. They're going to be charged for an image they don't need. And when that image comes back negative, the physician doesn't really have a whole lot of things to offer, right? So what they'll say is, we have tests, we have images, we have general recommendations, and we have referrals. That's the whole scope of treatment that the physicians have in this particular situation, right? So if we can see those patients first and actually help with that direct triage, assess those patients quickly because we can rule in and rule out musculoskeletal conditions with really great accuracy, we can actually get that patient back on the right pathway. So if it isn't a musculoskeletal issue, our physicians have confidence that they should be looking deeper. If it is a musculoskeletal issue, they can have confidence in us making the right treatment plan for that patient and getting that patient out of the ED and onto the next best step as quickly as possible. So the results of that actually improve operations in the ED, reduce cost, improve satisfaction, and implement physical therapy in a way that it should be implemented.
Yeah, that is wonderful, and that I think there's an abundance of economic evidence that shows that everything you're saying is held to fruition even a year put past the need for that clinical encounter. So then let me follow up with this question. Once somebody encounters your service in emergency department, what are some of the next steps? Have you found that you have a direct collaboration with a traditional in-person systems, or do you let the patient kind of go off and just find the right mechanism of aftercare?
So the problem with the emergency department is so many people have limited access to follow-up care. So the concern is that each discharge plan really has to be customized to that patient, right? And if you give the patient an unrealistic discharge plan, it's a useless discharge plan. So I can say, you need a custom lightweight wheelchair and you need 24-hour supervision and you need to stay someplace without stairs and you need this and you need that. But the patient is unfunded. They have no family support. They have nothing to rely on, right? I've given them nothing and they'll be discharged with exactly that. So each patient really has to have a very specific discharge plan. And the other thing that we're finding, like from a health literacy perspective and an access to care perspective, and from screening patients' social determinants of health, that if we're able to actually implement a realistic discharge plan and set it up for them, like facilitate as much as possible, like actually helping that patient who doesn't speak English get an appointment set up with the right specialist, with an interpreter, with all of those pieces in place, their follow-up is going to be a lot better. And that sounds costly and it sounds like it takes time, and it does, but what it prevents is bounce back to the emergency department, which also saves costs and saves the patient this runaround time where they don't know where else to go but back to the ED. So spending that time and investing that time in discharge planning is sometimes the most effective thing we can do. So when I look at this chart that's on the screen here, I'm absolutely like doing the patient triage, I'm doing the rapid assessment, I'm doing education or exercises. But what I would change that education and exercises box to truly is patient management, right? We're not technicians providing an intervention, we're providing comprehensive management of that patient. And that includes a heavy emphasis on realistic discharge planning, in addition to whatever interventions that patient might need.
I actually really like that. So patient management, because of the entire portfolio of clinical tools and products, goes well beyond education and exercise to what we do, and you're managing the encounter, right? So then And actually, I have a personal agenda with the word discharge. I think discharge should be safe for something that comes out of your body, not something that is happening in a clinical encounter.
Well, if it makes
But
you feel better, I have a similar feeling about the phrase allied healthcare professionals.
yeah, yeah, what does
I
that
feel like
mean,
that
right?
bias us directly to the sidelines when in cases like this we should be directly in the front lines. So we can both have our soapboxes there.
Oh, right on. And I agree because that really means nothing, right? Allied health means allied health. It's a label that was put on us 50 years ago to classify fee-for-service structure, CPT codes, and it hasn't been updated in 22 years or more.
Right.
So then how would we change it? How would we change the word discharge into this more of a continuity and continuation of resources, especially in a patient population that doesn't always have resources or access to a traditional care? So what do we do instead of discharge? What's the last step that ensures a reduction in a need and improvement in clinical outcomes for this vulnerable patient population?
I think that's where we're running into this crisis with primary care providers, right? Because we should be able to have an effective disposition that we then punt on to the cruise director, who's the primary care provider. But in a case like this, where the patient really needs physical therapy, this is where we need our primary care physical therapists that are like actually managing people's wellness and referring out for people's medical care, right? So that's a missing link. And again, access continues to be an issue and physical therapy continues to be a luxury. So what we have to do in the emergency department, right, is it's like Semisonic always says, you don't have to go home, but you can't stay here. So really all I can do is get you to that next best step as efficiently as possible. But then beyond that, like my reach of power really ends. And that's where we need community partners to take that next step towards top of scope practice and get upstream. And when we talk about transforming society, which is one of the most beautiful missions I've ever heard in my life, I'm going to assert that we have to go to society to make that happen. We can't keep waiting for those patients to make it to us. So instead of waiting for these people to choose PT first by going to outpatient, we're going to the ED where they're finding themselves. But then we need to have a community network that shows up to support society when it comes out of the ED. So my hope is that somebody listening to this is like, yeah, now I'm going to fill that gap.
Yeah, yeah, for sure. And then I think it's a point of when somebody says, "Yeah, I'm going to fill that gap." What are the resources available to them, and how do they access these resources to become a primary care physical therapist, to become empowered by primary care physical therapy? And before I go any further, we have aired a slide that allows you to take a survey. So while Dr. Riff is answering this question, if you can go on Slido and answer this question: do you think physical therapists are ready to serve as first point of care for musculoskeletal patients in the ER? So yeah, what are the resources that are available to a traditional provider to become this emergency room professional or in a primary care professional?
I think the first thing that I'd like to assert is that I'm just going to tell you what I think. We are fully prepared. And the worst part is we're globally behind. Like I'll have the international physical therapists who practice in the ED like message me and they're like, we don't even understand why you have a platform. We've been doing this for years. Like what are you doing? Like why is this even a thing? And there are physical therapists in the emergency room in Australia who can have direct admit privileges to the hospital when necessary. They're managing fractures. They're doing all of these things that we could and should be doing. And a lot of these physical therapists in other countries are even less educated than we are. So I think until we truly, as physical therapists, really own our scope of practice and the fact that we are already prepared to lead in these settings, we just need a little more audacity, I think. We're going to be stuck. So I think the first resource is just that faith in the fact that you have this training. And we need to stop imagining only what we're allowed to do and start thinking about what we should be doing. And I read a quote this morning that was like, in every time travel movie, somebody goes back in time and they think that if they just make one small change, it'll have this ripple effect on the future. But everyone sitting in the present, it never occurs to them that they could make some small change that will create a ripple effect in the future. And that's where we end up in this conversation about top of scope, top of license, and top of facility. So we get kind of stuck there. But I think there are a lot of resources for people who do want to practice in these settings. There's primary care certificate available through the APTA. There's continuing education courses to prepare you to really help from a systems management perspective. There are continuing education courses to help you feel prepared to practice in the emergency department. And then there's just like having faith in the lived experience that you have, the clinical skills that you have, and the knowledge that you are the right provider to do this. So there's lots of things out there. But the first step really is to just have the audacity and the faith that you are the right person to do that. Can I give you like one example about that?
I insist. No, absolutely.
So one thing that I ask in one of the courses that I teach is that the case involves a patient coming in at a cervical collar. And maybe I'll just ask people how they feel, and you can react to this if you want to. As a direct access physical therapist, which everyone in the United States is a direct access provider in some capacity, right? We should be. That's top of license. That's not even top of scope. Would you feel comfortable putting a cervical collar on a patient?
No.
They come into your clinic, you receive their history, you hear their mechanism of injury, and you're like, would you feel comfortable putting a collar on a patient? Hopefully the answer is yes, because you now need to make that decision about where that patient needs to go next. But then the converse of that is, if that patient comes to you in the emergency department with that collar already on, do you feel comfortable and confident removing that collar? Or do you feel like a physician has to do that? Who do you think is actually more competent in the decision-making process to remove that collar?
I think part of it becomes more customer service than a discipline-based competence. Where customer service is, especially in a traditional setting, you're always afraid of alienating a referral source. So even if you feel like the color is not in the proper fit, there's some external contextual factors that reduce your likelihood of making the best decision because you are always playing defense instead of playing offense, which actually is a perfect leeway for the next segment where in the ER, oftentimes you find yourself being the only musculoskeletal professional and the only physical therapist working, right? So that in essence, it's a solo practice. And as a business, right? As a business model, it has its benefits and it has its constraints. Have you found that being a solo physical therapist in the ER, you were able to learn and absorb some of the other practice methodology from your colleagues that are physicians or nurse practitioners or other? And how has that influenced your own practice as a physical therapist?
So I have been told that I practice in the emergency department like I own a private practice, and the emergency department is the community that I serve. So I've got my referral sources, I've got my community members, and I think that's absolutely the way that you need to practice so that you're making those autonomous decisions and you're not a technician filling orders, right? You're a doctor who's providing patient management for the patients that are part of your community practice. But I would even say you're not even operating as a musculoskeletal specialist. You're operating more like a private practice owner in the middle of nowhere, right? You have to see anything that comes in the door, whether that's congestive heart failure, whether that's vertigo, or maybe it is just an ankle sprain. But you have to be prepared to doctor at that top of scope level, even in this area. And so what I've absorbed most from my colleagues is number one, shared decision making makes better patient outcomes. We may need to practice autonomously, so we're making our best judgment as physical therapists. But then after that, we need to collaborate cohesively so that the patient is getting the best of all of those levels of expertise. Think how much education is available in that department. And if we can leverage that from a very lateral hierarchy perspective and come together, we're going to make exceptional decisions for that patient at an important time of service. The other thing that I've learned a lot about is risk tolerance. And I feel like physical therapists have absolutely appalling risk tolerance. We're so careful that sometimes it's the detriment of our patients. Like we know there's an epidemic of underdosing our geriatric patients, for example. And, the number of PTs that send patients into the emergency department for hypertension, and the physicians are immediately discharging those patients because there's no emergent management needed. Like we need to be better and be more critical thinkers and stop thinking about red flags as hard stops and start thinking about them as factors that come into the entire decision-making process. And whether you're an autonomous provider in the middle of nowhere with your own practice, or you're an autonomous practitioner in the middle of an interdisciplinary team, that risk tolerance needs to be the same. The communication needs to be the same. That cohesive collaboration has to be the same. And I think that's the only way we're really going to move healthcare forward. We have to stop being so siloed.
100%. So I think that there's an interesting parallel here, right? So what, in your opinion, what are some of the ways, potentially in a more rural setting? So if you are a solo practitioner, if you have a small private practice in a rural setting without any close large hospital systems next to you, so what stops a private practice physical therapist from opening their walk-in urgent musculoskeletal care practice? And what do you think are some of the potential barriers and some of the benefits to their community if they provided additional access for some of these emergent situations, especially when they're emergent in a musculoskeletal sense?
I would tell you we're already doing that. Like there's a clinic in Montana that's an urgent care musculoskeletal walk-in clinic staffed exclusively by physical therapists. There's grant funding to like help reproduce this model all across the United States. Additionally, when you think about sideline PTs, combat PTs, they're doing exactly that, right? So it's not a novel concept. It just needs to be applied at a larger level. So I don't think there's anything exciting about that other than the fact that we're not doing it. We need people to actually get up and do it and have the confidence in that. And one of the things I also talk about is using digital triage or telehealth to keep patients out of the emergency department as well. But as long as we continue to expect patients to come to us, expect patients to have banker's hours, and expect to only see patients who are well-funded and well-resourced, we're truly not going to move these patients forward. We're not going to transform society. We're going to only get that segment of society that can pay to play. And they're going to go to these resource areas as well and end up in the wrong avenue of care. And physical therapists will continue to have less of a market share of those patients overall, which is not what we need.
Yeah. So then how does this fit into some of these emergent payer models? And specifically, so how do you become a resource then for potential emergent situations that apply directly to a consumer or directly to an employer? How do you become a strategic partner with urgent care centers in the community? How do you scale this? So even if there's funding available, how do you scale this so that you become an immediate resource and an immediate point of contact for musculoskeletal complaints in your community, circumventing the traditional PEP-dependent model?
Well, I wish I was smart enough to answer all of those questions. But what I will tell you is that you have the knowledge to do that already. And what that is you just do a physical therapy evaluation on the space that you want to enter, right? So if you want to be in the urgent care model in your neighborhood, you need to do an assessment on that urgent care. You need to receive their patient history. You need to identify their impairments, their functional limitations, and their participation restrictions. You need to identify their threats and their opportunities. And then you need to build a plan of care to get into that space and provide access to patients. But it all goes back to being able to set patient-centered goals. And those patient-centered goals might be this urgent care has this much volume of musculoskeletal complaints. We can serve that at this cost, and your throughput time will be better, your outcomes will be better, your bounce back rate will be better. There are also physical therapy models where there's physical therapists embedded in the urgent care a few days a week. They are an outpatient a couple of the other days a week. So they actually fill their outpatient caseload from the urgent care. So they provide that urgent level care, then they're able to keep those patients on an ongoing primary care basis as well to continue to manage that patient's episode of care. So there's so many options. And that's what I say when I say we need to go to society. All of these structures already exist. We just need to go get in them. There's nothing really preventing us from doing that other than somebody, again, having the audacity and the initiative to go out and do that.
Yeah, absolutely. So let's quickly review the survey that we just conducted. We actually had an excellent response, and we're almost caught in the middle where do you think physical therapy are ready to serve as first point of care in a musculoskeletal patient in ER? And 60% of respondents answered yes, PTs are fully prepared to lead the clinic in the setting. And then 40% responded that maybe I think PT could, but additional training and support is needed. So do you share this, that potentially we just need to offer additional services or additional certifications? And like, we hate these, like PTs love the alphabet soup, but maybe put like the extra letters after your name to ensure that you are capable of handling an emergency type of a situation. What do you think of that survey?
I get that. I get that. I have an NCS. I have finished my fellowship in orthopedic manual therapy. I'm a letter person. Like, I like that. It very much appeals to my achievement-based brain. But like, the reality is that physical therapist practice in the emergency care is not a specialization. It's a generalization. And we need to be specialists at being generalists. And I think the other thing to remember about that is that that PT that's in that area is not accountable for the entire plan of care. They're just accountable to evaluate and manage that patient one time, right? And get them on to the next best specialist. And when people ask me, should EDPT be a specialty? Should it be a residency? Should it be a fellowship? I don't think that's the case. We really have this focus on graduating physical therapists who are excellent generalists, and we need to lean into that. I don't know that being a specialist really serves in any specific way. You have the skills that you need, you just need to be confident in them. And I was recently on somebody's PhD defense, and hopefully this information will be published later this year, ideally, or maybe next year. And what they found was, after surveying EDPT practices all over the country, was that the biggest predictors of success for PTs in the emergency department was not how many letters they had after their name, or what their skill was with low back pain or differential diagnosis even. It was like specific character attributes that were actually the most helpful, whether that was flexibility, time management, decisiveness. All of those things were more the factors for success, as opposed to you don't have the clinical skill set necessary. I think you do have to be innovative. You have to be decisive. You have to have high risk tolerance. You have to be an excellent communicator, and you have to be able to leverage your familiar tools in really unfamiliar ways. You can't go into every room and be like, I'm going to have you do active range of motion with overpressure. Like, they might be prone screaming on a gurney. You have to find a different way to get the information that you need. But I think we're well positioned for that. We just haven't imagined that we can do that. But once you're forced to do that, you'll find that it's really very natural. So it's more about those external factors. If you like to know what your day is going to be like ahead of time, this is not for you. If you want to prepare the night before, again, not for you. If you want to see the entire episode of care, this is not for you. But if you want to help people find a huge delta change of relief in one session, this is for you. If you want to see people and get them next to the right specialist, this is for you. If you like coordinating care and working with other medical professionals and being with people in some of the absolute worst moments of their lives and making hope just a little bit more tangible for them, this is definitely for you.
Yeah, and I think the important part to mention here is having enough intellectual humility to know what you don't know. I think
Exactly.
right? Like the typical clinical setting, we unfortunately a lot of times take on every encounter and every case that comes our way because there's an economic pressure to absorb some of these patients, especially in a skinny months of the year. Right? January, February, March, you're unlikely to be turned away from a traditional PT practice because that's a revenue generator. But I think being in this emergency department setting, you are practicing probably the best type of allied health. Well, pardon me, physical therapy profession, because you are able to really rule in or rule out musculoskeletal involvement and then pass it on to the next professional, which is part of being a larger member of the healthcare organization. So with this, we are on to our second survey of the day, which is what is the most important factor for successful scaling of PT practice in ER and raising awareness in your community. So strong clinical training in ER, I'm glad you just covered it, Dr. Griffin. Leadership and advocacy within the hospital community, collaboration with physicians and care team, and patient education and visibility in the community. And so while this is the survey is going on, I will ask you about measuring the value of physical therapists in the emergency department. So what are some of the benchmarks and what are some of the KPIs that the hospital potentially uses to evaluate your clinical efficacy to justify your presence? And how do we translate some of that into a traditional physical therapy setting?
Yeah, so I think when you look at emergency departments, again, you need to understand what their benchmark factors are, right? So there are a lot of components that go into that, whether it's throughput time, bounce back rate, services utilized, hospital admissions, bed lock, like all of those things are things that go into those factors. So really, when you're looking at what you need to measure for your specific emergency department, again, I'd suggest you take an impairment-based approach. What is your ED struggling with that? And then apply how physical therapy can actually assist with that. So turnaround time, huge, like throughput time, massive. If you can prove how physical therapy reduces that by tracking your turnaround time for these patients, then you're in business. If it's avoidable hospital admissions and your hospital is overflowing with patients and they're being held in the ED, can you make a plan of care for these patients and get them out quicker? So it really, I would say the factors for success are really emergency department specific because they have things that they need to work on and metrics that are important to them. And the worst thing is you just don't want to make any of those metrics worse, right? So I think step one is understanding what are the key metrics for that ED. And then what are the key metrics for you as a physical therapy team within that emergency department as well? Usually discharge, getting patients through the emergency department, avoiding hospital admissions, protecting the resources of the ED, all of those things are going to be your number one factors.
Sorry, Manoj, would you mind silencing the mic? Technical difficulty. We're experiencing technical difficulty as we speak. Yeah. So like I think that's absolutely correct, and it's right on. And I appreciate you saying that. So because this is a tech company, and because you have such a unique perspective on physical therapy and care delivery, what are some of the pieces of technology that you have seen being utilized in a emergency care setting, and what are some of the pieces of general technology that are available to physical therapists that can enhance and capitalize on optimal care delivery process, and how do we get them there?
So a lot of emergency departments are very algorithm based. And the reason for that is to help decrease unwarranted variation of practice. We talk about that in physical therapy as well, right? If you go to this emergency department or this emergency department with chest pain, ideally the workup looks the same, right? You have best practice, standard of care, chest pain workups in every emergency department in the United States, ideally. So I think opportunities that we have in the ED to implement technology would be like having those best practice algorithms and referral patterns in place for when physical therapists should be implemented into care, and then following that patient's care trajectory. Also, from the communication standpoint, when we talk about streamlining documentation for patients in the ED, I always tell clinicians that that note that you're writing has to be directed to the right audience. And so that can be time consuming. Is my goal with this note to give this information to the physician? They're probably not going to read the note. Is it so that the physical therapist who receives this patient has their baseline measurements? Is it that I need to justify a piece of equipment to the company that's going to deliver that? Is it that I need to justify a referral and admission to acute rehab? So I need to write all of those in different ways. And so streamlining templates is one way that we do that, so that we can allow physical therapists to deliver the right communication to the right people in a really streamlined and like concise type of way. So those are some of the main ways that we use technology. What I would love to see truly is like some kind of technology that would follow the patient in the gap. So whether that's like getting them set up with a mobile telehealth app, where they could have a physical therapist that would check in with them immediately the next day until they bridge that gap to that next level of care, or like a specific plan of care that they could follow through an app if we suspect it's going to be a limited like episode of care. Like most likely this patient who came in with an acute whiplash type of injury, if they follow the steps in the app, they will likely be able to self-manage that. And my goal with that is not to eliminate physical therapists, but again, allow physical therapists to be the right provider at the right time and seeing the patients that really won't be able to self-manage. So I think having some of those resources available for patients over time would be extremely helpful, and someone that they could leverage questions to, especially if they don't have the resources for follow-up. So having things like that available for our underprivileged patients would be amazing as well.
Yeah, awesome. Absolutely. And I think one of the things that we as professionals have to be is we have to understand when there's a redundant, low-value tasks that we engage with on a daily basis. How do we automate these tasks? So there's just a lot of things that we do because we've been indoctrinated to do them, but machines do them better. Like technology does a good job processing large points of data. Technology does really much better job capturing some of the ambient sound, right? So if you're using a digital scribe feature, like it's just you no longer have to be the typist. Technology also reduces some of the barriers of communication because these templates that you were just mentioning, Dr. Griffith, these templates can be optimized for your specific cohort, patient cohort. So you no longer have to be manually inputting all of this information. And then ultimately, in a traditional sense, the revenue cycle management, reducing some of the burden of these sludge points, these friction points that traditional payers put, which is like your prioritization process. These things that act as a huge stick in our wheels that we can greatly reduce their burden and their impact on our care provision because technology does a really good job with it. So I think it's not whether PT or technology, it's PT with technology that is the only way for us to translate into the future. And so like it's really interesting to hear your perspective, and really interesting to see how our global US-based PT cohort is taking this on. So let's review the results of the survey, and I would be love to hear your input from it. So again, what is the most important factor in successfully scaling PT services in the ER? Now, and so 43% of respondents responded that patient education and visibility in the community. With the second most popular response, collaboration with physicians in the team, and an equal amount of leadership and advocacy and strong clinical training. So most important, like patient education and visibility in the community. What do you think of that?
I think that from that perspective, we don't want patients to come to the ED for physical therapy. So I'm not going to go out into the community and advertise that that's an offered service, right? I would much prefer to see that community effort on patient education around outpatient clinics, around home care clinics, around telehealth, so that patients know how and when to access a physical therapist, or even using that digital triage to keep patients out of the ED. Because ideally, I don't have a job in the ED because there are patients are getting seen with upstream care in other models of care, or they have quick immediate access to physical therapy using other tools. So for scaling in the emergency department, even working with physicians goes a long way, right? They'll advocate for you. They'll be excited to have you in the emergency department. But bottom line is, if you don't work with the administration of the hospital at large that directs all of that and the administration, your practice is not going to go anywhere. And in fact, it might be seen as something that impedes progress or a barrier to care in the emergency department, especially because it's not well known. So the biggest way to scale and advance your clinical practice in the emergency department isn't through training, isn't through patient satisfaction. It's really what administrative barriers can you solve for the hospital. And one of the best things that we can do is keep people getting the resources that they need. So we're focusing on the patient and respecting the resources that are available in the emergency department. Thinking about the emergency department as the front porch to the hospital, you don't invite everybody in off the front porch. So if we can manage your needs on the front porch rather than bringing you into the house, we need to do that. So putting more resources up front in the ED actually protects the resources of the health system at large and uses them most appropriately. So that's what I would say is usually the best way to do that. It's obviously a multi-pronged approach where you need all of those factors, but definitely looking to administration first will lead to long-term sustainability.
And absolutely, long-term sustainability is where it's at, right? It's not a short game; it's a long game, and so we're all involved in the long game and seeing where it can go. So for this question, especially for us, and kind of continuing the conversation from a couple of months ago, where I think I want us to spend a couple of minutes waxing poetic about the physical therapy, art and science of physical therapy, right? Like, so is physical therapy art, or is physical therapy science, or is there a point of equilibrium where equal amount of art and science, and we are like the most important factor is how patient and human centric can we be? So I'll let you expand on like the art and science tension point in physical therapy services.
Well, what I usually tell students is that physical therapy lies at the direct intersection of art and science, right? And that what we do is we bring the humanity into science. And there are obviously other professionals that do that well, but I think we do that so well. And part of that is that, ED physicians might save your life, but we're going to give you your life back. Physical therapy in general really helps make hope tangible. It makes function real. And so that also takes an art. When you have to get a patient to do a particular thing, you have this goal for the patient, they may not have the goal for the patient. It's that shared humanity that allows us to truly provide patient-centered goals and patient-centered care. Because what might be important to us as physical therapists might not be important to that patient. And developing therapeutic alliance is one of the biggest gifts that we have to offer. And it's one of the biggest gifts I think we receive as physical therapists. And I call that like the sacred ordinary, that like connecting with a patient. I read that in a book, and I can never remember what book, but that sacred ordinary moment of human connection that comes with what we do. And not every physical therapist has to be at that level. I think that's the other piece that we need to let go of, is that physical therapist practice is not just direct one-on-one bedside care. It's remote therapeutic monitoring. It's health promotion. It's looking at public health. It's looking at city design. It's looking at, legislation. It's all of those pieces, but it's taking like the humanity and science of movement and then integrating that into society at large, in addition to those sacred moments at the bedside. So I think technology is actually a way that we can do more for more people, because you can help people one-on-one. But I think there was a study, I think it was World Physiotherapy Association, that said if we saw every patient who needed us, not even every patient who would benefit from us, and I'm talking like zero preventative care, we're only seeing 7 to 10% of the people who actually need us. And each one of us would be responsible for like 20,000 patients or something like that. And in places like Kenya, it was like one PT for 2 million people or something ridiculous like that. But that really stuck with me. We have to find a better way to reach more people. Again, going back to that concept of transforming society, we can't do that only with one-to-one care. And we need to find a way to take the art that we provide in healthcare and scale that at large so that we have a healthier society. Because I would love for us to truly, truly get upstream in healthcare, not wait for people to be injured, not wait for people to be ill, not wait for people to fall off the waterfall in the emergency department, but to truly focus on making people well and referring them out for their medical care.
Yeah, that's like beautifully said, I think, and I couldn't just thank you for saying that. There's an interesting economic assessment of presenteeism and economic impact on just the United
Yes.
States economy, right? So it's like $2 trillion of lost revenue from these essentially walking wounded people with musculoskeletal complaints that are compromised in their performance and their ability to work, that are just not pursuing care and are not seeing care because of all of the points that you just mentioned. And so how do we become a resource to these people, both through the emergency department, but then also through a traditional physical therapy setting? Like there's just an abundant opportunity to be a resource and a caretaker of these people that do have problems that are just not getting access, and potentially referencing and leveraging digital systems and RTM systems and everything else. So
Well, I think a really great example of that too, from a neurologic perspective, is stroke, right? We are in stroke rehab care from the emergency department and back to return to function. But the real flex is in risk management, right? So that patient never has a stroke in the first place. And where are we there? Where are
yeah.
we there? Who's there? We should be there. So thinking again upstream, if you take nothing else out of this talk, I hope that you realize that we need to think outside the box. We need to move upstream in the continuum of care and think about the spaces we should be in that we're not.
Yeah, absolutely. And then actually like taking yourself out of this box and then putting yourself into a more of an innovator role, right? So let's move to
Exactly.
questions from our audience. And the first question is actually brilliant, where emergency room visits are episodic. Conventional PT visits are consistent with the plan of care. Is there a conflict between the emergency room and a traditional setting for a physical therapist?
So, two things that I would say. The first one is I want you to stop thinking about conventional PT visits, right? Like, this is not a conventional PT setting. It's not a conventional PT visit. And if we continue to only think about physical therapist practice from a conventional perspective, we're going to continue to be stuck in that system where we're paid based on codes, we're paid based on time, we're paid based on whatever. Like, we need to stop thinking about this is the way we've always done it. This is the way we'll continue to do it. But I understand the question is more about that conflict. I provide my patients an entire plan of care. I just address that plan of care in one setting, in one sitting, basically. And sometimes not. Sometimes those patients have to stay in the ED for a couple days. Sometimes they're there for longer if they're waiting for authorization to go to rehab or something similar. Sometimes we rehab those folks in place. But that plan of care, I set a plan of care. I make goals for that patient. I achieve those goals or I do not. And then that patient is moved on to their next episode of care. So that PT visit is episodic, but it's still an entire plan of care. And I would argue that in the outpatient clinic, we could have episodes of care just like that. A patient may come into the outpatient clinic. They might not need 6 weeks of care. Their concern might easily be addressed with one visit or a follow-up visit 2 months later. So thinking from that perspective is we don't have to do it the way we've always done it. And the more we get stuck there, the less we're going to see opportunity for us to be present and practicing.
Yeah, taking ourselves away from the comfort zone of this episode-based system that you treat every encounter as a standalone encounter, not seeing the bigger picture and the continuity of care, and being able to be the resource to an individual in need, right? Essentially being a liaison towards optimal movement and optimal musculoskeletal health. So there's another question that is right on. So, and then this one is a little bit more payer-based. So how do you see insurance carrier barriers to having physical therapy being an urgent care emergency provider? Example, needing referral to CS. So
yeah, so I'm the first to admit that somebody called me a visionary without a plan. I'm totally fine with that label. I don't have all the answers. But what I would say is that if you are collaborating and providing urgent or emergent care services in just a physical therapist run situation. You still need to understand what resources are available to your community. And I would highly recommend that you partner with a physician partner or other medical partner so that you have resources to address those concerns. In the emergency department, obviously not a concern. There are medical providers abound. It's definitely not an issue. But every state has some form of direct access at this point. And so what I would suggest is just working with that. Now, if that patient's insurance is the problem, then that patient has to make a choice. Will they receive care here based on their particular insurance plan, or will they access care elsewhere? But what I would like to see is that top of scope mindset where we're actually going to our state legislatures, working with the Division of Insurance, showing how we can actually reduce costs with urgent and emergent management, and having them start covering those services immediately because of the cost savings. So one example of that in Colorado is, in Colorado, you can now see a physical therapist without prior authorization, without paying a copay for up to 6 visits for a pain-related complaint as a mechanism of combating the opioid crisis. And that was directly accomplished with advocacy, with legislative advocacy through the APTA. So looking for solutions like that. So do I have the solution now, but do we need to work towards a solution? Absolutely. And in some cases, even if you are receiving cash-based payment services for these patients, it's still cheaper than going to the emergency department or the urgent care, right? So I always tell PT students, if you want to pay off your student loans, go to the hospital, set up a tent outside that says, have low back pain, stop here first. Just charge less than they get charged inside, and you're in business. So thinking about that and just giving patients as many options as possible to reduce access to your care, I think is the ultimate solution to that.
Yeah, being able to meet your patient at the right place, being able to provide the right resource at the right time, and being there for them, right? There's another question from the audience, and how does one think about PT utilization when operating in the ER, especially low payout per visit or episode of care in this case? So like the fee-for-service model, and has that at all been addressed, or has that all been a problem in this type of setting?
So what I would tell you is I don't think about it at all. I just provide patient care. And it's one of the most liberating, wonderful things ever. I see whoever's there, whether they can pay or not, whether we get paid or not. And it's amazing. But I will tell you that we bill just like outpatient PT clinics, just like everyone who works in an outpatient clinic. Insurance payers pay us just as robustly for our services as they do for those of you in outpatient. So, we're not making a cash cow, but it's usually enough to actually pay for the physical therapist's salary in the emergency department. And if you think about the acute care setting in general, physical therapists in acute care are not revenue generators, right? They're value generators. They provide value to the hospital. So there's not usually that conversation about we need to worry about the low payout per visit of care, because the hospital knows that the value isn't in how much money they receive for this service. The value is in how much money they don't lose from this service. So acute care physical therapists never worry about payment, reimbursement, right? All of that's bundled into the care that's provided in the hospital. But the hospital prioritizes paying for physical therapists because of the outcomes. And it's the same in the emergency department. So we bill for what we do, not what we'll get paid for. And I don't think about it at all after that. I've only had one patient that I'm aware of that came back and complained about the bill that they received. And ironically, it was a plastic surgeon. So
Yeah, figures, right? So that's actually, I think, what you just said. I hope every member of the audience just remembers this, because I think those are the words to live by. That there's revenue generation and there's value generations, and they're not dichotomous. They're complementary. And so when in a traditional setting, in any setting, as a physical therapist, as a clinician and a professional, you revenue generation is important to keep the lights on, but value generation is what we do as a part of the larger healthcare system. So how do you generate value as a professional? So we have one last question before we have to stop, which is, I've encountered more physicians who feel physician practice is being encroached by nurse practitioners and PAs, and they're saying we can do anything the physicians can do. Have you encountered this? What strategies do you use in the ER to hospitals and other specialists? So,
I think that we have less of an issue with this because we definitely have a unique skill set. And I haven't really ever felt like we've had this barrier, especially when we started taking direct triage of musculoskeletal complaints away from nurse practitioners and PAs specifically. Like we ran a pilot where The physician did the highest level of triage, and then that patient was basically discharged to the physical therapist. So they didn't ever see another healthcare provider other than us after that. If we needed more medical management, we would go back to them and involve them in that care. And there was some concern that the NPs and the PAs were going to feel like we were taking their job, that we were displacing them. But after they were able to see how we were operating and how we could work together, what they realized is it gave them a lot more time to focus on the patients within their specialty. And I'll have PAs and NPs say, I didn't go to school, and physicians, I didn't go to school to learn how to treat low back pain. I'm here for emergencies. So please do everything within your skill set, within your scope over here, and we'll work together. But then I can do everything in my skill set and my scope over here. So I think in this perspective, we're a little bit different because we don't have as much of that overlapping skill set. It's more collaborative as opposed to replacement based, if that makes sense.
Absolutely. So, Dr. Griffith, thank you so very much for being a part of this process. Thank you for all your contribution to the field of physical therapy here in the United States. And thank you for continuing to lead. I think it takes a lot of courage to lead, and you have been a leader. So, again, grateful for your time. And I really thank you for the last hour, which I think provided an immense amount of value to our listeners. So, thank you. Keep it up. And everyone, thank you for attending this webinar.
Thank you so much.